Special Report.
For any further assistance, press *0. Thank you. I would now like to turn the call over to your speaker today, Ms. Andrea Anand. Please go ahead.
Thank you, and thank you all for joining us for the COVID-19 media briefing for November 6th. On the call today, we have MDH Commissioner Jan Malcolm, MDH Infectious Disease Director Chris Erzman, MDH Health Regulation Director Michelle Larson, Annette Greeley, President of Jones Harrison Residence in Minneapolis, and Minnesota Department of Administration Assistant Commissioner Aaron Campbell. After some updates from our presenters, we will open it up to questions from reporters on the line. So with that, I will turn it over to Malcolm.
Thanks, Andrea, and good afternoon, everyone. Well, the United States set another record yesterday, adding 122,000 cases in a single day, bringing the total to now 9.6 million cases of COVID-19 in our nation, and over 234,000 total deaths, an increase of 1,210 from yesterday. It continues to be a global phenomenon as well, of course, with another 621,000 cases around the world in a single day and over 8,560 deaths around the world. Now, here in Minnesota, unfortunately, we are announcing again new highs in both testing and positive cases. In fact, this is our fourth consecutive day of setting a new record for new cases. We received results on 45,769 lab tests yesterday, with 5,454 of those being positive results. This brings us to a new total of 170,307 laboratory confirmed cases of COVID-19 in Minnesota. 986 Minnesotans are currently hospitalized, 56 more than the day prior. 212 of those are in intensive care units, 15 fewer than the day prior. Sadly, another 36 Minnesota deaths were reported yesterday across 20 counties, 13 in the metropolitan area, and 23 persons from greater Minnesota, bringing us now to 2,563 of our fellow Minnesotans who have died of COVID-19. These are sobering numbers, to be sure. The weekly change in cases has gone up by just under 16%, up from 12% the week prior. And this rate of growth in our cases is double the rate of growth in our testing. These testing volumes are very high, but continue to grow even so, week over week. We had 8.3% more tests processed in the past week, up from 7.4% the week prior. Importantly, and very concerning, the 7-day average testing positivity rate has jumped up to 9.8%, up from 7% the week prior. And as you know, we've been concerned since we crossed the 5% rate not so long ago. This test positivity rate clearly shows that finding more cases is not just a matter of testing more. We are testing a lot more, finding a lot more than we're testing. Since well before the first COVID case was reported in Minnesota, we've been working with long-term care providers in specific to share information about the COVID threat and what needed to be done in long-term care settings to protect residents and workers. The reason for this focus has certainly been borne out by the course of this epidemic. Residents of long-term care facilities include seniors, but as well younger adults living with illness, traumatic injuries, memory loss, or disabilities. Together, these are some of the most vulnerable Minnesotans for contracting severe cases of COVID-19 and dying from it. In early May, under Governor Tim Walz's leadership, we in Minnesota stepped up our work at the health department and in local public health, working in partnership with long-term care facilities by rolling out a 5-point plan which focuses on people living in nursing homes and assisted living facilities. This plan has made facilities safer and has helped to make outbreaks more of an exception than the norm. We have a full update on the long-term care plan available on our website, but I've asked Michelle Larson, the director of our Health Regulation Division, to join us today to run through just a few of the highlights of our progress on this call. Thanks for joining us, Michelle.
Hi, thank you, Commissioner. Hi, everyone. Thanks for having me today. I'm going to give you a 5-point plan update. The last time you heard from me was this summer, and we've been doing a lot. Commissioner Malcolm said we've been working for many months to increase outreach and support our long-term care facilities. From March through October, the department helped more than 2,320 facilities with their infection control measures. Over 435 visits, both on-site and remote, have been made for infection control and technical assistance. And all nursing homes in Minnesota had regulatory on-site visits with a special focus on infection control. For today's call, I will just provide a few updates for each of the 5 areas of focus in the governor's plan that was announced back in May. And again, more details can be found on the MDH website at health.state.mn.us. So the first point, expand COVID-19 testing for residents and workers in long-term care facilities. We have developed testing criteria and a process for facilities to request testing services for residents and workers. Testing capacity initially was made possible through the Minnesota National Guard and has now transitioned to using 8 contracted swabbing teams that operate around the state. And since April, the State Emergency Operations Center has coordinated testing for more than 750 facilities and 170,000 staff and residents. On average, the State Emergency Operations Center teams swab roughly 50 facilities a week. We've partnered with laboratories within and outside Minnesota to ensure long-term care facilities have timely access to testing services. By late October, at least 40,000 tests were being done each week in long-term care. The second point in the battle plan, provide testing support and troubleshooting to clear barriers. We've created streamlined processes for facilities needing state assistance to get testing resources and support, and established a standing physician order ready for long-term care facilities that do not have a medical director, so that facilities can order their RT-PCR tests more easily. We've started a nurse triage line for those facilities using the state-provided ordering physician. The triage line provides COVID-19 test results to facilities and individuals and advises them on potential next steps after receiving test results. We continue to provide extensive guidance, education, and technical assistance to facilities to implement new state and federal requirements for testing, to understand how to access and when to use new testing platforms such as antigen and saliva, and to address barriers that arise to facilities conducting testing. The third point in the battle plan, get personal protective equipment to facilities when needed. We've pushed out personal protective equipment to long-term care facilities in waves starting in April. This included gowns, hundreds of thousands of face masks, and millions of gloves. We've provided fit testing to healthcare coalitions to support long-term care facilities with fit testing for N95 respirators, and we provided caches of personal protective equipment to healthcare coalitions from the state warehouse to support long-term care facilities with personal protective equipment needs. The fourth point in the battle plan, ensure adequate staffing levels for even the hardest hit facilities. We've created a crisis staff manager team to give technical assistance to facilities. Crisis staff managers are available to address issues and connect facilities to staffing resources. At-risk facilities are identified through a special ranking and prioritization process. Outreach and education was provided to facilities to aid in development of contingency, as well as crisis staffing plan prior to the occurrence of a crisis. We launched a process to deploy National Guard and federal staffing support teams to facilities in staffing crisis. Over the last 4 weeks, these teams have assisted 7 facilities. We've partnered with the Department of Human Services in development on a staffing pool implementation and provided assistance with the triage process to facilitate services to those eligible. We've worked with the Department of Human Services and our Department of Economic and Employee Development to help grow the pool of employees available in the staffing pool. Notice of the work opportunity was distributed to nearly 80,000 unemployment insurance recipients targeting the hospitality and healthcare industry. A media campaign highlighted the need and amplified the message statewide. The fifth point in the battle plan, leverage our partnerships to better apply their skills and talents. We are working with the statewide regional healthcare coalitions. This includes local public health, hospitals, healthcare systems, emergency medical services, and emergency managers. This partnership is really important because healthcare coalitions serve as a centralized regional response organization to ensure effective coordination among local and state partners, transparent and frequent communications, and fulfillment of resource requests. To varying degrees across the state, local public health has provided outreach to, consultation with, and support for their long-term care partners by providing support with testing and staffing, facilitating connections between long-term care and healthcare coalitions, and offering infection control consultation in long-term care facilities. So that covers the 5-point battle plan update and all the work that we have been doing since May, since that has been proposed. I do want to give you an update on our visitation guidance. In addition to the challenge of protecting residents and workers from COVID, the state has worked hard to protect residents' mental, emotional, and social well-being by keeping them connected with family and friends. So in July, Minnesota was one of the first states in the nation to roll out an essential caregiver program, understanding the toll prolonged separation of visitor restrictions is having on residents' overall health and well-being. This guidance allows family members and other outside caregivers to provide care and companionship to residents in person. In August, Minnesota rolled out broader visitation guidance to allow for more visitation, which was further revised and updated in October. The results of this in trying to balance emotional well-being and infection control continues to be a priority for us as we see an explosion of COVID-19 in the communities surrounding our long-term care facilities. While the state as a whole saw new cases skyrocket by 73% from the beginning of September to the end of October, new cases in long-term care facilities increased 15% at that same time period. As of November 3rd, our data shows that 8% of Minnesota's 368 nursing homes have never had a reported case. 53% of Minnesota's nursing homes currently have an active outbreak, meaning that they've had a case within the past 14 days. Only 10% of Minnesota's assisted living facilities currently have an active outbreak. Of Minnesota's 1,692 assisted living facilities, 60% have never had a reported case. The number of new cases in congregate care facilities, including nursing homes and assisted living facilities, has slowed significantly over the summer, but we are concerned to see that activity has been increasing amid the overall increase in state. Even one death is too many. Deaths have not reached former peak levels, but they are increasing. Commissioner, I'm going to hand this back to you now.
Thanks for that update, Michelle. We're just incredibly grateful as State Department of Health for the strong partnerships and the great work that has gone on over the last few months to protect long-term care residents and workers. But as we've been saying for quite a few days and weeks now, even the best flood walls can fail if the waters rise high enough. And as community transmission has steadily marched upward, we are concerned, as Michelle has just outlined. We now have 66 Minnesota counties with a 14-day county percent positivity rate above our caution threshold of 5%. We know that higher rates of virus transmission in the community increase the risk for all community members, and especially for residents and staff in long-term care facilities. We've had 1,104 cases among staff and long-term care residents in the last week alone in long-term care facilities, which include group homes and other types of congregate care facilities in addition to skilled nursing facilities and assisted living. And for context, the last time we had over 1,000 cases in these congregate care facilities in a single week was back in May. As cases continue to rise, the residents and the staff in these facilities are at serious risk, even as these facilities continue to take aggressive action to limit infections. Long-term care facilities, with our assistance, have truly made great efforts to keep their residents and staff safe. However, their good work cannot completely insulate facilities and residents from the high rate of viral transmission in communities surrounding them. All too often, the virus enters the facility because staff are exposed through their community interactions, likely by other people who don't even know they have it. And as the number of cases in the community continues to increase, it's increasingly likely that these hard-won safeguards will be compromised. And the consequences of this can be grave, and we're seeing that with increasing number of hospitalizations among long-term care residents and sadly increasing deaths. That's why you hear us on these regular media updates imploring Minnesotans to do their part to slow the spread of COVID in our communities, because we can. We've made such really impressive progress in these high-risk environments in long-term care. That progress is now at the risk of being undermined, not undone, not by the facilities themselves, but by the communities around them. We need every single Minnesotan and all communities to share our common values, which I believe we do, to prioritize protecting our most vulnerable family members and neighbors, and to ensure that we are not transmitting the virus to long-term care residents and staff. We can all do our part and keep up with those core public health prevention principles of attending to distance between people, social distancing of minimum of 6 feet, wearing our masks when we're in public or in close proximity to people, inside or outside, staying at home when we're sick, avoiding large gatherings, and getting tested when it's appropriate to do so. With that, I want to thank Annette Greeley, President and CEO of Jones Harrison, for joining us again today. I'll turn it over to you, Annette.
Thank you, Commissioner Malcolm. I just want to thank everyone for this time to share an update. Since I've last spoken, we have been doing testing at Jones Harrison of our staff, staff weekly, and almost every week we have 1 or 2 positive employees. These staff are usually asymptomatic and go home to quarantine for a 2-week period. We feel testing has been an effective tool, though, in keeping our fight of COVID out of our buildings. We also continue to test residents as needed to follow up after our staff results. And we're grateful for the relationship the governor and Commissioner Malcolm have created with the labs, such as Mayo, to help us be able to test adequately. In terms of PPE, we are in a continual state of procuring masks, gloves, and gowns. We're working on having an adequate supply in case of another outbreak. Knowing we have the support, though, of MDH and the governor's team to help with reimbursement of these supplies is a huge relief. The support of MDH has never faltered and is a vital part of our facility's COVID-19 team. We know that even as the virus has spread and the demands on MDH has grown, they have always been available and supportive to us. As we head into the winter months, we plan on using the same tactics of testing, using proper PPE and infection control to help keep COVID-19 out of our buildings. The only other tactic we need is the support of the citizens of Minnesota to take measures such as social distancing and masks to help curb the spread and keep our seniors safe, whether in our facility or in home in their own community. Regarding our visitation, that has been a tricky balance. We started our visitations at Jones Harrison for our care center, but we've had to suspend it due to a positive staff person. Our assisted living was able to have visitation longer, but is currently suspended due to a positive staff person. We still have visitations, though, over video and our essential caregiver program. And we try to balance that we know our families absolutely need to visit and they need that connection with each other. But we also carry a priority of keeping our residents healthy and minimizing the risks to them. I would say lastly, prior to COVID-19, our industry was facing staffing shortages, and today we estimate there's still around 10,000 jobs available to help care for seniors in Minnesota. We are glad the governor's team with DEED is working to help educate people on this great career area in healthcare. During this time, I would encourage anyone looking at making a career change to look at caring for our seniors in a variety of settings. Our seniors would love to meet you, and you will love knowing that they want to see you. You will actually make a difference in someone's life. Thank you for this time. Andrea?
Thank you very much to all of our speakers today. Operator, we are ready to take questions.
All right, so as a reminder, to ask a question, you will press star 1 on your telephone. To withdraw your question, press the pound key. Again, that is star 1 on your telephone. Please stand by while we compile the Q&A roster. We do have a question from Jeremy Olson from Star Tribune. You are now live.
Commissioner or anyone else, today the state dashboard was recalculated the number of available ICU beds and the total number of immediately available ICU beds by about 200, which means our capacity isn't as immediately available as we once thought it was. So I wanted to return to you with a question about whether you're concerned right now that our hospitals are out of intensive care space and whether any steps need to be taken.
Well, thanks for the question, Jeremy. And those updates to the dashboard, I think, reflect ongoing effort to make sure that the data are as accurate as possible and fully reflect staffed capacity and not just theoretical physical capacity. And as I know you know, and we don't need to get too into the weeds on this, but there have been a lot of changes in federal reporting requirements that also influence change in the numbers. But yes, it is the case that ICU capacity in the Twin Cities metro area is particularly limited right now. Statewide capacity looks a little better, but that certainly can and does fluctuate at a local level, literally daily, if not hourly. Just as an example, while there were 23 available ICU beds in metro hospitals yesterday, on the 4th, there were 22. 17 on the 3rd, so just as an example of the ups and downs. But things are absolutely getting tighter in Minnesota. A week ago, we had 36 available ICU beds in the metro hospitals as an example. So yes, it's very important that we keep an eye on these metrics, that we be very, very focused on the reality of staffed beds and not just theoretical beds. And that is, again, part of why you just keep hearing us stress the importance of doing all that we collectively can to help protect this capacity by doing what we can to slow down community spread, which is clearly driving these issues. We've talked before about the fact that hospitals have been running very full all summer and fall, and with non-COVID business. COVID patients have been a very small percentage of these full hospital numbers until quite recently. And now the added COVID-19 growth in cases is putting our hospitals near the top of their capacity. And staffing is becoming an increasing problem. That said, I just continue to stress that health systems are working very closely together. It's just an unprecedented level of collaboration and data sharing with each other and with us at the State Emergency Operations Center. The process that we have in place for assisting hospitals in finding ICU placements when needed is really working very well. So again, I just want to note that we've built some systems to help us manage our way through this, but there are these numbers, these trajectories are very concerning. And it's just why we keep appealing to Minnesotans that there's so much, that our behavior is what's driving this, and there's so much we can all do to help keep this capacity available.
A brief follow-up, because the governor has frequently said that his overriding goal with the pandemic response is to make sure that when someone needs a hospital bed for COVID, that they have it, seeing some of the situations in Italy and others on what happened. People didn't have beds when they needed them. With that in mind, I'm assuming you don't want to wait until you run out to react. And that's make me wonder if you're considering any kind of dial back in the coming days, whether it be in elective surgeries, schools, business openings, anything that is it coming?
Well, as we've continued to, we're looking at the data literally, daily and hourly, and in conversations about what things are likely to have the greatest effect. And as we've said, so many times, but we just never can say it enough. If Minnesotans were following the guidance that currently exists, we wouldn't need further dial backs. However, just given the fact that we've not seen some of those behavior changes, we just need to keep getting that message out. And I think with the numbers being as dramatic as they've been in recent days, we're hoping that what may have people might have become a little numb to the numbers, that perhaps these rapid increases will catch attention and folks will really think hard about the role we all play in this. But we are and we will continue to look at what policy tools might be effective, focusing in on where we see some of this transmission, which, as I mentioned, is really challenging because it's literally thousands and thousands of small decisions happening all over Minnesota that are the issue here.
Thank you.
Next one on the queue is Emily Havoc from Care 11. You are now live.
Hi, thank you for taking my question. Mine does overlap with Jeremy's a bit. We're hearing anecdotally that there are people at smaller hospitals that have been turned away from ICU transfers because there isn't a place to send them. Can you comment on that or confirm that? Do you know if that's happening? And if so, like what processes are in place to get that person to bed if there isn't available?
I am not aware of any requests for assistance in transferring that have not been able to be fulfilled. I guess it's possible that a hospital might not have been aware of that coordinating center process and not used it, but certainly it's incumbent on us to get the message out to everybody that process exists and how to use it. But I've not heard of any inability to place patients that have come through that system. And Chris or anybody else on the line, I don't know if you have any other data that you could contribute here.
No, I have not heard that either, so not aware of that.
And then as a follow-up, is there any update on potential overflow capacity that could be opened up here in the coming days and weeks as we see these beds fill up?
Well, as we talked about, the health systems have done a lot of work in recent months identifying capacity that could be freed up within the hospital, and that is certainly the first priority, is to keep people needing hospital-level care in the hospitals. And actually, some of that is already happening. That's at the individual hospital level or health system level. They're reallocating staff and beds already by just making use of those additional spaces and setting their priorities for services depending upon their capacity and their staffing, literally on a daily basis. So it's a very dynamic situation, and our hospitals already are using a lot of that flexibility and capacity they've created, and I think that's certainly as the numbers keep going up. There's an absolute limit on that at some point, but we do have we think a really well developed system of using the available space and available staff in the most flexible ways we can. And again, this centralized coordinating system for making sure that intensive care resources, people can get to those, is really, I think, an asset that we have in Minnesota that is somewhat unique among our peers.
Thanks, Commissioner. If I can just sneak in one more follow-up here, is there a possibility that a doctor would request a transfer then to an ICU bed and that would be denied? Like, who makes the call in terms of how serious it is and if that person really needs the bed?
Well, I think that's always, of course, a matter of clinical judgment at the bedside. But this process that I've described, and we can certainly get Dr. Hick on the call in the near future here to give you more detail on this. He's spoken on these calls before about how that coordinating center process works and how clinical decision making kind of gets shared. I would really want to ask for his expertise on answering that.
Thank you.
Okay, next one on the queue is Catherine Richard from Minnesota Public Radio. You are now live.
Yeah, hi. Staying on the hospitals question, I've been speaking to a lot of doctors the last few days who are working on the front lines of this, who are saying that even under the very best case scenario where there are enough beds and supplies, they don't have the staff to deal with what they kind of describe as a double whammy of increased patient volume and also staff just being out for COVID-related reasons. So I want to know, does the state have a plan to recruit additional staff, either from other states or traveling healthcare workers to fill this gap, or is it going to be up to the individual hospital systems to do that if they need to?
Well, Catherine, I think we're just acknowledging the importance of the point that, and we've made this point ourselves several times now, that it isn't just beds, it's staff to provide the level of care needed in the beds. And we know the health systems are doing a lot of work internally and again with each other, talking about creative staffing solutions. We do have a medical reserve corps that is aimed at getting qualified clinicians who are able to volunteer to help out. As services get reprioritized, some staff who are then become able to help fill some of the expanded need for acute care, for example. But the issue of staff recruitment is always something that the systems are doing. There are nurse pools and traveling physician organizations. The difficulty that we face now, unfortunately, is with COVID on the rise all over the country. Some of that surging of staff that we've seen in hotspots earlier in the pandemic is now being really stretched very thinly, broadly over the country. So we're going to be looking at together with the hospitals and with the State Emergency Operations Center at how to think creatively about what other ways might be able to extend some of the staff. And we certainly can talk more about that in the days and weeks ahead. I think it's important planning that we do, and we are kind of taking the next step, if you will, on trying to create some scenarios of how we would handle different levels of growth.
Okay, thank you.
This is Chris.
Sorry.
I just wanted to add to something. I think that all the things that the commissioner has described are really important. All the work that's been done throughout the pandemic to plan for hospital capacity and staffing on the part of our hospital system. But that's really looking at the downstream response to cases. And I think, even as that's an important part of the story, I think the most important message that we need to get to the public is that you have got to make changes. Your choices are impacting the capacity of our healthcare system to serve you and the other people that need it. And I think we want to keep, we want to describe what's happening to respond, but I think we want to keep going upstream to look at what is causing this. And it's the high number of cases, and we really need people to take this seriously and to make some changes so that we can get ahead of this and not be responding downstream with creative solutions for staffing, but rather that we are upstream and making a difference in the case counts. Thank you.
Thanks, Chris. Very glad you came back to the core point. Thank you.
Operator, we have time for one more question.
Okay. For the next one, we do have Chris Megan from Pioneer Press. You are now live.
Hi, I just wanted to follow up on the restrictions or dialbacks. With the rate of cases and hospitalizations and deaths over the last week or two, I just can't understand how some type of dialback can't be part of your thinking to get this under control. Are you just concerned that it's too late, that the cases have already spread beyond the point where dialbacks have an effect, or do you fear that folks just won't actually abide by them this time around? How is it not part of your strategy right now?
Well, it certainly has always been part of the discussion, and I think what we're really searching for is what's going to have the greatest effect. I think you've heard the governor speak to his preference for strategies that will be the most focused on where transmission is happening. Really very evidence-driven and targeted approaches. And you raise a fundamentally important question: if people aren't following the current rules, what kind of additional rules can we put in place that would have a better chance of people adhering to them? So it is absolutely an ongoing discussion. We certainly are watching and learning from peers in other states as well about the degree to which those any policy levers like that, like dial backs, have or have not shown an effect. So it's a very active conversation.
Just a quick follow-up on that when it comes to testing. Obviously, breaking records and tests very often as well, but from what we hear, demand is even higher than what's available. How much more demand is there out there compared to our testing capacity? And is 50,000 a day anywhere near what we need to understand the pandemic in ways that we can help control its spread?
Thanks. That's a great question, and that is precisely correct. That despite our growth in testing capacity, we still have more demand. And actually, there's a couple of things. There's just the kind of the strategies and the logistics of how you get the test, closer to people so that they can take advantage of the capacity that's there, because we have more capacity in the system right now. Getting the tests available to people, getting people to use the test is part of what we've been doing. So that's led to the creation of many more saliva collection, semi-permanent sites, many more kind of community pop-up events, if you will, as well as working with the health system partners to try to reduce barriers to testing there. But we've talked before about the point that Dr. Birx made when she visited a few weeks ago now about the need to keep on building up the testing capacity so that we can actually go do some proactive screening, looking for people who are asymptomatic and may be positive and have no idea that they are, as a way, to Chris's point a minute ago about trying to get upstream of this to reduce the cases on the front end and not just try to manage them on the back end. So we will continue to push on expanding testing availability. We are closely evaluating new types of tests that are kind of coming into the ecosystem to see what types of tests are the most useful for what kind of circumstances. So we've put a big push on diversifying our types of testing, our testing supplies, so that we can keep growing the capacity, because clearly 50,000, that was a big and unimaginable stretch at one point in time. And now we think we need to significantly increase it from here in order to meet it.
Thank you, Commissioner.
Thank you very much. That's all the time we have for today. If you didn't have a chance to get a question answered, please feel free to reach out to our MDH Communications office. Thank you all for joining us. We will talk to you again next week.
This has been a WDIO News Special Report.